Good evening, everyone, and welcome to our Understanding the New Chronic GP Chronic Condition Management Plan Framework for Allied Health Providers webinar tonight. My name is Fiona Quigley. I'm the Senior Manager of Workforce Development at Westvic PHN, and I'll be your facilitator this evening. Alongside me is Jade, also from the Workforce Development team from our PHN. This webinar is a collaboration between the Victorian and Tasmanian PHNs, and we're very pleased to be providing you this webinar tonight. I'd like to begin by acknowledging the traditional owners and custodians of the unceded lands and waterways that we're all calling in from this evening across Victoria and perhaps further afield. We recognise there's diversity, resilience, and the ongoing place that First Peoples hold in our communities. We pay respect to elders, both past and present, and commit to working together in the spirit of mutual understanding, respect, and reconciliation. We support self-determination for First Nations peoples and organisations. You can view our upcoming events returning in February next year. We have our Emergencies in Primary Care Echo starting up on Tuesday mornings. We have 2 more webinars for the rest of the year: Better Billing in Women's Health and Family, Domestic and Sexual Violence Spotlight Series. You can also view the majority of our webinar recordings freely on our PHN Learn YouTube site. We'll put the link to access our recorded webinars in the chat for you. You may have seen that we've recently launched our new Learn and Network monthly newsletter. It's the best way to stay up to date with our latest education opportunities and upcoming events. If you haven't received an edition yet, please subscribe via the link in the chat or scan the QR code that's now on the screen. Editions are released on the first Tuesday of each month. There's also a link in the chat where you can submit your education and training requests for inclusion in our 2026 education calendar. A reminder about Health Pathways, a free online resource with localised clinical and referral information for health practitioners across Western Victoria. A certificate of attendance will be emailed to participants. Please take a moment to check that your full name is displayed accurately on the screen. If not, or you're unsure, please rename yourself or type your first and last name in the chat box now. This will ensure we can issue you with a certificate of attendance. This event is being recorded. Please keep yourself on mute for today's session. Due to the high number of registrants, we will take questions through the chat box. Please feel free to type questions in the chat at any time, and they will be addressed during the presentation and at the end of the presentation. Your feedback is important to us, so please take the time to complete the event survey after the webinar. There will be a link in the chat box after the presentation. So the presenters this evening are Riwka Hagen, as a general practice expert and former practice manager, and Luke Armstrong, diabetes nurse educator. So I'm going to hand over to Riwka and Luke now to start the presentation.
Fabulous. Thank you so much, Fiona and Jade, for the warm welcome to tonight's event, and a big thank you to all the attendees for rocking up at 6:30 at night when you should be having some dinner and being with your families. So we really appreciate your time to be with us this evening. It's a reasonably sort of meaty topic, so we're going to try and keep it as light as we possibly can. Luke and I are really looking forward to your questions as well. So please feel free to pop them into the chat box, and we look forward to discussing those. So I'm going to just hand over to Luke. He's going to very quickly run you through this evening's agenda. Thanks, Luke.
Thanks, Riv. Just echoing what Riv mentioned earlier, obviously welcome to tonight's presentation, and we're hoping that you can take something away from tonight. So just for the agenda tonight, we're going to obviously go through the old and the new framework that came out on the 1st of July. We'll talk about the MBS numbers and fees. Obviously, we'll be talking about what's changed for the GPs. That's probably not related to your services, but it's important to be aware of those. The new referral requirements for allied health professionals and the impact that it has on practices. We're going to talk about those transitional arrangements from that GP management plan and TCA into our new GPCCMP. Talk about some practical elements and tips. And obviously, please ask questions. As Ruth mentioned, we will try and address those throughout the session, but if we don't address it throughout the session, we can talk about it at the end. There are some amazing resources available, which we will be able to send to you after tonight's recording. There are also some learning objectives. So understanding the new GPCCMP framework, talk about the referral processes which have changed, identifying what GPs are doing differently and the impacts it has on your practices in allied health, and understanding the transitional arrangements and billing implications.
Fantastic. So we thought also before we really kick off, you might like to know a little bit more about Luke and myself. Many of you won't have met us before. I generally float about in the general practice space, and that's why many of you won't be familiar with me. My background is initially as a medical scientist many, many years ago, and I worked in the space of hematology and immunohematology for quite a period of time before I got my entry into primary care and then primary care management. And through those pathways, I've, I guess, intersected with many health organisations across the country. And in the last decade or so, I've run medical business services, which provides consultancy, advisory, coaching, training services throughout Australia. And this is how I intersect with lots of practice managers and nurses and GPs, and at times allied health professionals too. So this is pretty special for me. On top of that, I've got some directorships that keep me really interested and involved, especially in community health, which has such a big overlap with allied health services as well. So that's a little bit about my background. And Luke, would you like to tell our audience a little bit about your background? And you can certainly mention how we've met and just a bit about your experiences.
Awesome. Thanks, Riff. So welcome everyone. So my background is as a registered nurse. I started off at the Alfred as a psychiatric mental health nurse, which was a really interesting experience throughout that sort of section of my career. I then completed a postgraduate certificate in diabetes education and management, as this was an area I was really passionate about. Managed to land my first diabetes education role at the Royal Children's Hospital. Worked there for 2.5 years before sort of transitioning into adult practice at the Austin Hospital and the Baker Heart and Diabetes Institute. There, I was sort of getting a bit of a taste of private work, just with some of the endocrinologists that I worked with, and I started my own private practice called Diabetes Wellness Coaching in Collingwood about a year ago now. So, I'm still relatively new to this space, but as all of us are, we're still learning. There's lots of change going on, and we're hoping that will be for greater good. But the way this sort of opportunity came about was Riff's mother is actually a patient of mine. So I commenced her on an insulin pump earlier in the year, and we're seeing some really great results. But since then, Riff and I have just had sort of loose conversation, and this sort of opportunity arose tonight. So hopefully I say the right things, but
Absolutely.
it's a really casual conversation, and hopefully you can take a bit away from it.
That's it. We're here to support each other. It is, quite a curious background to how I absolutely roped Luke into doing this session with me, and that was because Westvic PHN sort of said we want more than just Riwka or a representative from primary care. We really want the voice of allied health to come through, and on that basis, Luke is here tonight. So it's absolutely joyful. So let's just have a look at what's changed since the 1st of July 2025. So we're talking about in the last 6 months, there have been some significant changes. And what I'll talk you through is from the primary care perspective. Again, not that you need to know any of this off by heart, but it will give you a little bit more context as to why some of these changes are coming through, the way that patients with chronic conditions might be landing on your doorstep with new referral forms and new information. So in essence, before the 1st of July, there was a long-standing arrangement whereby patients with chronic conditions were entitled to receive what was called a GPMP, a GP management plan. And that was kind of the starter service to a team care arrangement. And that was the secondary service that kind of kicked off the enablement to receive allied health subsidised through Medicare for patients. So what's happened since the 1st of July is that two-step approach has been thrown out the door, and we now have a single service for chronic disease management, and that's called a GPCCMP, or a GP chronic condition management plan. And that's the folding together of the GP management plan and the team care arrangement all into one. So it's a simplification for the primary care sector. You'll recall before the 1st of July, you would have received for chronic condition patients through the GP what was called an EPC, an extended primary care referral form, which was completed by the GP, quite a templated form that would give you the information about the patient and, very importantly, the number of services for your allied health that were sort of, authorised by the GP to be provided. That's changed, and now the requirement is for the GP just to write a referral letter in the same way that they would do when they are referring patients to a specialist service. So it needs to contain certain information, and we'll run through all of that, but it is absolutely a simplification of that old EPC referral form. Prior, the GP needed to nominate the number of services that were to be provided by each allied health discipline. That is no longer required, and I'll be very curious to hear some feedback from the audience to see whether you're getting really loose referrals from GPs and you're going, what am I supposed to be doing with this? So we'll have a little bit more of a talk about what sits behind that and how that impacts on the services that you're providing as well. Earlier too, we needed the referral form to be actually named to the specific allied health provider by name. That's no longer required either. So you can accept a referral that is addressed to anybody who matches your discipline. So whether you're a physiotherapist or a speechy or any other type of allied health provider, the referral form may not necessarily have your name on it. So that could well cause some confusion for you as well, but that's entirely permitted now in this new space. Also, prior to the 1st of July, there was a requirement both on the GP and the allied health provider to show evidence of collaboration, and you'll see that that's kind of put into the inverted commas there. And that was quite a convoluted process, and different providers will have had different experiences with different practitioners and practices about how that actually played out. Sometimes it was massively convoluted. It would be perhaps a phone call or a faxed letter that they were asking you to respond to in terms of your agreement to participate in the chronic condition care for a particular patient, and providing an outline of the services that that you think you might be providing. So really clunky, very bureaucratic, not a lot of common sense in any of that. And GPs and certainly allied health providers found that really, really tricky. That's all gone by the wayside now as well, and that's a really good thing. And now what's required is a pretty straightforward communication of service outcomes. So whether it is a phone call or a letter, or however way you communicate with your general practitioners of the services that you are providing and the service outcomes that you've been able to achieve. So pretty straightforward. There's no sort of template methodology around that. You simply describe what you've been doing and how that's impacting the patient. And then finally, in that bottom row there, you'll see some item number changes. So previously, the GP management plan was an item 721 with a particular rebate, $164. The team care arrangement, the 723, was another reasonably hefty Medicare rebate that was attached to it. And then there was a review process at about $82. So you can see from those earlier rebates that for general practitioners, the financial driver was on actually creating GP management plans and team care arrangements. And then the review process that came after that was much lower value, and therefore it kind of dropped off the radar for many, many practitioners. So from a clinical service perspective, there wasn't a lot of sort of ongoing proactive care happening in the GP space. And that's why some of these changes have kind of come through now. So what for primary care the space looks like now is that the creation of a GP chronic condition management plan, the GPCCMP, is now $156. And the review item is the exact same rebate, and that is to just take away the imperative to only provide the care plan and then let the ball drop for the next, 2 years or so until that needs to be done again. So it's the equalisation of fees that hopefully sees the uptake of far more proactive and planned care for patients with chronic conditions. So in a nutshell, they are the key changes that have happened since the 1st of July.
Riwka, we have a question.
Yeah, go for
a
it.
couple of questions in the chat about
Sure.
patients' eligibility for their 5 sessions and how do professionals know that? And so, when do they write their final letter back to the referrer?
Yeah, okay. I'm going to park that one because we're going to come to that. We will discuss all of that in quite some detail. Great question. And this is exactly the reason why tonight is an event, because these elements are just, really quite tricky. But we'll just park that, and we will absolutely cover that in a moment. I'm going to hand back to Luke to give us the good news about the things that actually haven't changed since the 1st of July. Take it away.
So obviously change can be really daunting, and having some sort of familiarity with our previous process is important as well. So obviously the things that haven't changed is the actual rebates that people will receive from allied health services, which is 6180. The Medicare item numbers for each allied health profession still remain the same. There still are group services available. So this is probably something that, particularly in diabetes education, I find is a sort of service that isn't getting utilized sufficiently enough. The Medicare item descriptors as well, but also those people who haven't yet got a GPCCMP in place, they can still use their previous GP management plan and TCA prior to the 1st of July, sorry.
Yeah, that's exactly right. And what that means is that the old EPC referral forms, if you've still got services left over that haven't been delivered yet, you can continue to provide them until they run out. So that's important to remember as well. And some item numbers here. Luke, do you want to run through those?
Yeah, so I'm presuming we've got a breadth of allied health professionals here today. So those item numbers do not change. you'll probably notice there that down the bottom, so obviously each allied health profession has a specific item number, but it's really important to note that for telehealth and telephone services, that telehealth number is the same for all the allied health professions as well as the telephone. So that 93000 and that 93013 for telephone services. So it's really important for the people you are seeing that they have a chronic condition and complex care needs managed by a medical professional other than a specialist. They have a GP chronic condition management plan in place or prepared or reviewed in the last 18 months. Just like we talked about on the previous slide, if they do have a GP management plan and TCA in place prior to the 1st of July, they have up until the 30th of June 2027 to utilize that. It's important that the service is at least 20 minutes of duration. And remember, they have up to 5 services per calendar year. And that Medicare rebate is $61.80.
So that's the basics of the item numbers. And as we've kind of been putting our slide deck together too last night when Luke and I caught up, we kind of went, look, you guys, the allied health professionals, you might not be looking in the MBS guide all that often, but we want you to be aware that the URL is right here, mbsonline.gov.au, gives you, it's essentially the Bible of Medicare, what you must do and what the rules and regulations are. So you can see that we've got a 10960, and apologies, I'm not wearing my glasses, so that's quite small font on my screen. It outlines the service eligibility for physiotherapists in this space. So it describes what the item deliverable is in the blurb as you look up those item numbers. And that's really key. That's sort of the core requirement of what you must do in order to remain compliant with the requirements of Medicare. Of course, really important too is the Medicare rebate. And as Luke indicated, 6180 hasn't changed since before the 1st of July. And importantly too, there are explanatory notes. Now, this is really interesting because I know too in primary care, these explanatory notes, they look really legalese when you look at it just in the view that you've got here. And you might be going, well, I'm not quite sure what that is, so I'm just going to leave that alone. But we'd really encourage you to click into each explanatory note that relates to the item numbers that you provide, because that's essentially where all of our information has come from. It gives you far more detailed insight into the background and the rationale for what you must do, and it really expands from just the few words that are the item number descriptor. So if you're not familiar with MBS Online, absolutely, this is one of your key takeaways, to note down that URL, have a little play and put in the item numbers that you use, and you'll find a wealth of information. Obviously, it contains information not just for allied health, but for primary care, for specialists, for for hospital services, for pathology, radiology, procedural work, the whole lot. It's a huge resource, and this is really the source of truth for everything to do with Medicare compliance. So in terms of the allied health group services, as Luke was saying before, these fly a little bit under the radar, and they are not applicable for every allied health modality, and it is restricted for patients with type 2 diabetes only. So that's the only clinical scenario under which allied health group services can be provided by 3 allied health professionals, and they are diabetes educators like Luke, exercise physiologists, and dietitians as well, so for dietetics. So if any of these are within your wheelhouse, you might want to know that there are essentially two types of services under the group services arrangement. The first is an assessment. So if a patient is referred to you as a diabetes educator, a dietitian, or an EP, and you think that this patient could benefit from group services, and let's face it, type 2 diabetics are inherently suitable for group services because of the interaction it provides with other patients, learning from each other, and kind of, running educational sessions for patients as well. The first kickoff event is an assessment service. So the allied health professional needs to ascertain that the patient is suitable to undergo or to participate in group services. And so these are specific item numbers according to which allied health professional you are. The Medicare rebate for that is $79.30, but the service must be at least 45 minutes. So it's a comprehensive assessment in readiness for group services. Similarly, for exercise physiologists, there are the assessment item numbers there, and for dietetics as well. And then the follow-up service is the actual group service, and they must be at least 60 minutes in length. And the idea is that you have a minimum of 2 patients in a group. So you can't have a group of 1, but you can have a group anywhere up to 12 people getting together. And for each of those patients, a Medicare rebate of $19.75 applies. So you can imagine that if you get a group of, say, 10 type 2 diabetics together and you provide an hour session, depending on whether you bulk bill that service or not, you're then talking about just on $200 for the hour of Medicare rebates that are appropriate for that service. And just lastly, again, I don't want to lean too much into the group services, but for dietitians, there are options for providing video assessments and a telephone assessment. So only for dietitians, not for diabetes educators or exercise physiologists. They can provide those services via video and phone. And for the group service, for the dietitians, you can actually host those services via video links as well, something like Zoom or Teams. If you can get a group of patients together, that is entirely reasonable. But again, like I said, not for diabetes educators and not for exercise physiologists either. So there's a fair bit to sort of digest in that. I'd love some feedback in the chat box too. If you are one of these specialist providers or allied health providers, and either you are or aren't providing group services, what do you think about this? Is this a new opportunity for you? Is that something that you could plan going forward as well? Now, I just want to lean into just a few of the mental health services available as well. Again, this is not the key focus for tonight's session, but we just want to point you to the individual and group services available too for mental health services. And that depends again on the modality or the allied health professional who's delivering those services, whether they are clinical psychologists or registered psychologists, occupational therapists or social workers. They have different item numbers available for their services, and they also are able to undertake group services under certain circumstances. And in terms of video services there too, they are restricted to patients in the MMM areas 4 to 7, and that's a measure of rurality. So this is only for rural and remote locations where it's actually really difficult, A, to get providers into those regions. So it's making mental health services available to patients who would otherwise be missing out. But for the sort of more regional base, the MMN 1 to 3, which, would be sort of the larger towns within the rural areas as well, those services are not available via via telehealth services. So just keep your eye on where you're providing services. Again, if you are a mental health clinician, could there be more opportunity for providing some of these services to patients outside of your normal catchment? So again, just some opportunities that you might want to have a bit of a think about. Now, this is a really interesting one as well. I did not know this before I started investigating all of the allied health services and the impact changes of the various plans. I did not know that also family and carers of patients with mental health conditions are able to tap into some of these mental health supports as well, which I think is just fantastic, up to 2 services per year. So again, different item numbers depending on who the provider is of those mental health support services. And again, just keep in mind the carers of the patients that you may already be dealing with. So then we kind of come to the allied health services for Aboriginal and Torres Strait Islander patients. And Luke and I had like a really big conversation about this because yet again, this is one that really flies under the radar. And that might be because GPs may not be identifying patients as being of Aboriginal Torres Strait Islander descent. And so you may not know that there are additional service opportunities available for these patients. Let me just quickly run you through what those service options look like. So we're in I guess, opposite to the 109 numbers that we've been talking about for the straight out allied health services that stem from a GPCCMP. There are also the 813 numbers, which is only for Indigenous patients. So patients must be of Aboriginal Torres Strait Islander descent, and they must have a referral from their GP either after a GPCCMP, so the referral pathway that we've just been talking about could kick off these item numbers, or it could be through what's known as an Aboriginal Torres Strait Islander health assessment, a specific item number that GPs utilise that also opens up this referral pathway to these allied health services. And the beauty about this, and why I get a little bit excited, is that this cohort of patients essentially has a double service eligibility compared to the general population. So instead of being entitled to 5 services per year, they are able to tap into up to 10 allied health services in a calendar year, so from January to December. Double the service eligibility, and there are item numbers available to provide these services via telehealth and telephone services as well. And you'll note that the Medicare rebate is the same as the 109 item numbers that we've been describing. So just quickly, the totality of service capacity for Indigenous patients is 10 allied health services per year. It could be made up of 5 of the 109 item numbers stemming from the GPCCMP, plus 5 out of this service bucket, I guess, or it could be 10 of the 813 item numbers as well. Totality of 10. After that, Medicare is going to no longer pay the rebates on that. And again, we will come to how we're going to keep track of that in a moment as well. And just lastly, before I hand back over to Luke again, is just the item number changes that have happened for GPs. Again, just for your information, the preparation of a plan, so the GPCCMP can happen once every 12 months. A face-to-face, so a physical attendance will have the item number 965 attached to it. And there are also item numbers for what are deemed to be non-vocationally registered GPs. They get slightly lower Medicare rebates for essentially the same service, but they're outlined there. For GPs, they can also prepare those plans via video consultation, just like, you guys can provide some of these services as well. And then the review item number generally is the 967, exactly the same Medicare rebate, 156.55, and that can happen via video services as well. So I know that's a lot of item numbers that we're throwing at you, but hopefully that gives you just a little bit of structure structure around what's happened in the last few months. Over to you, Luke.
Thank you. And just reiterating, obviously there's so much to digest. Please head to MBS Online for a allied health professional in private practice. You know, this is all new to me as well. But yes, this website has been a game changer. So talking about the referral form requirements from the general practitioner. So there are some requirements that are needed by Medicare, and that is the name of the referring practitioner, the address of which they work at, their provider number of the referring practitioner, the date at which the referral was made. But it's also really what it doesn't sort of specify is that we talk about the 18 months eligibility of that plan. It actually starts from when you see that patient for the first time. Obviously, it needs to be in writing, and it can be an e-signature. So it's great that you're able to receive electronic referrals. They don't have to be faxed through. It's really important that it specifies why the GP is referring that patient to you. It talks about their background, their history, their condition, and what they're wanting from your services. Obviously, sort of mental health, better access initiative sort of falls into a different bucket. There are some additional requirements needed for that, just because only certain allied health practitioners can provide that service.
Yeah, exactly. And I guess the key change or the key difference there too is that the allied health professionals, the psychologists, whatever form that takes, they need to be instructed as to how many services they are requested to provide before they refer the patient back to the GP for a review with perhaps further ongoing service provision after that as well. So again, all of this comes straight out of MBS Online. We promise you we've not made this up as we've gone along. So yeah, the referral validity, that's an interesting one, isn't it? Again, Medicare often does like really clunky stuff. And from my perspective, this is one of them. I mean, keeping track of that 18 months is going to be, really pretty tricky. And of course, the real difficulty in all of this is that now that the GP is no longer required to instruct you as to how many services you are expected to provide, it's kind of yin yang, both good and bad. So the good about that is that you can negotiate with the patient to support them in the way that is most meaningful for that patient, whether it is 1 session, 2 sessions, or more. And I think the key message in all of this too is that we are asking GPs to explain to patients that the counting of the 5 services for which a Medicare rebate is available is now essentially the patient's responsibility rather than the GPs or the allied health providers. That you kind of, I guess, echo that messaging as well, so that when you do get a referral and you see a patient for the first time, that you let them know they're entitled to 5 in total. You are not to know where else they may be referred to, but let the patient know that only 5 will be rebated. And we'll talk a little bit more about, your strategy in terms of billing in a moment, but making sure that that communication is really clear, that you are very clear about what the expectation is. Well, first of all, from the practitioner, if they have specified what they think should be delivered, that would be a really good guidance. But if that hasn't been provided, that you can negotiate that with the patient. And of course, there are additional service opportunities that may stem from that at the moment might be just a little bit trickier to deliver, only because of the rigidity of the earlier referral process that was in place. So again, there's some good bits to it, and there's some bad bits to it as well. So a little bit about lost referrals. Again, this is one of these sort of head scratch moments as well, as far as Medicare is concerned. So what they say about referrals that have either been lost or destroyed, Medicare indicates that you can continue to provide a service or provide a first service on the basis of a lost or just missing referral. They do expect that this is not the norm, so that you wouldn't be routinely providing services to patients without having a valid referral in place. But by simply noting that the patient has lost the referral, that you are able to confidently go ahead and provide the service anyway. So the second point to this is that where the intended allied health or Aboriginal Torres Strait Islander healthcare provider is known, the referring practitioners are encouraged to send referrals electronically whenever possible to minimise that sort of loss of referral documentation. So absolutely from the GP side, we're really sort of stressing the importance of being able to send referral information electronically. Most GP practices are well versed with that, and we are really encouraging allied health providers to, if you haven't gone down that pathway just yet of accepting electronic referrals, now's the time to start thinking about that, because it's going to smooth this pathway of the referral process as well. And again, I'd be really curious to hear how that kind of rolls within your practice and what your experience is like. So let's talk a little bit about the impact on allied health practices, Luke. And this is kind of where the rubber hits the road, isn't it? About, well, so what? What are we going to do about this? Would you like to kick us off with this discussion?
Yeah, like I think seeing a few messages in the chat are probably related to sort of these talking points that we see on screen. So obviously the uncertainty of the number of sessions of allied health services intended to be subsidised by Medicare. And I think, as Riff was mentioning earlier, that's a really good opportunity as the healthcare provider to ask them, what are you wanting to get out of this care plan? Because that will have a bit more certainty in sort of the services that you're providing. Obviously, lack of control and oversight, especially if you're looking to bulk bill. Obviously being in private practice, you can't offer your services for nothing. So it's about sort of determining a sort of cost that you feel is needed for your services. The confusion for providers and patients. So sort of having that, which the last dot point really, really talks about, is that communication, communicating with the GP about your consults. So obviously that still remains the same, the providing a letter with the first and last of your sessions, in that GPCCMP. Obviously talking about sort of private bill patients, you can't bulk bill them and then charge them separately. I think Riff can talk about that a little bit further. And I think also what Riff was mentioning is it's putting that sort of onus back onto the patient. What are they wanting from this care plan? And having sort of open communication with all the healthcare professionals provided. And probably that last dot point should probably be at the top, communication.
Yeah, I think that's absolutely a fair point there. And I guess I really want to lean into just the strategy around and recommendation on privately billing patients. So where that comes from, and that's my recommendation. So this is just my opinion, and you are of course entirely free to set your strategy however you see fit for your practice. But what I would be saying is that if you are routinely bulk billing these allied health services that stem out of GPCCMPs, you do not have the assurance that you're going to get a Medicare rebate for it. There were still instances before the 1st of July when that may have happened as well, but it is far more likely to happen now that we have a lack of control over really knowing how many services are subsidised and how many services the patient has already received from other allied health providers. So I guess my thinking would be is to really think about a robust private billing strategy. So that's about communicating with your patients to ensure that they're aware of what the process is going to be when they see you. If you have been bulk billing in the past, there is nothing to stop you from simply charging the patient the Medicare rebate, i.e., the $61.80 as a private fee, which the patient can then claim back if they haven't used up all 5 of their services yet from Medicare. So that means that you're not charging extra on top of that. And you're going to be assured that you're going to get paid for the work that you do, which you may not do if you rely on bulk billing that service by billing Medicare directly. Of course, the other opportunity there is if private billing is going to be a desirable option for you, is to look at, well, does 6180 kind of cover the expected fee for the service that I provide? Remember, the service needs to be at least of 20 minutes duration according to the Medicare item number description. And is 6180 sufficient? I dare say the answer to that might be no. And I know that there are many allied health providers who are already charging well above that, certainly $80, $90, $100, sometimes more than that for these services. And then the patient is able to claim back that Medicare rebate if they are still eligible to do that. So I'd really encourage you to think about that, how you communicate that, and then the Medicare rebate rightly belongs in the domain of the patient and under the patient's control. It makes this whole process a whole lot simpler for you as an allied health provider. Now, I do want to note, and I've kind of highlighted that in yellow as well, to just remind you that what you can't do is bulk bill the service, i.e. directly bill it to Medicare and then charge a gap fee on top of that. And I really wanted to highlight that too, because occasionally we see this happening in general practice in primary care as well. It is illegal. Medicare absolutely frowns upon it. If you are not going to accept the Medicare rebate as the full amount that you're going to be paid, then you need to charge this as a private invoice, i.e. charge the patient the entire amount and allow them to claim that back. Whether you facilitate that for them in your rooms, through the various technologies that are available to you, or whether you simply give an invoice receipt to the patient to take to Medicare and claim is kind of by the by. But please don't bulk bill and charge another gap fee on top, not permitted. So that's kind of the nuts of it, isn't it, Luke? And I guess I'm really keen at this stage to hear a little bit more from you too about what your approach has been, especially in these early days of sort of transitioning out of public hospital service provision into this space. What's that kind of look like for you?
Yeah, I guess I was very lucky enough to transition from the public hospital sector to sort of a semi-private facility at the Baker Heart and Diabetes Institute. So it was sort of set up as a private practice, but there were means tested, so patients were billed based on their income. So I sort of got a bit of a taste as to an appropriate charge for patients. And sort of that transition into my own private practice, I did a bit of my own market research as well, looked around at different locations, to see what on average other credentialed diabetes educators were charging. You don't want to make your fees, super expensive so people can't afford to see you, but you don't want to underdo, sort of underestimate your skill as well. So for my sort of private practice, I very much, I would say, specialize in type 1 diabetes. So I've had to do additional training in regards to continuous glucose monitors and insulin pump therapy. So there aren't many educators, particularly in Victoria, that do what I do. So It's about sort of putting value on your time, and realizing that you are very skilled at what you do. Um, and obviously having that Medicare rebate has been really beneficial for patients too. And we were talking about this yesterday, and I'm actually really surprised how many patients aren't even aware of the GPCCMP. Um, so for myself in particular, because I do receive a lot of referrals from endocrinologists, I actually raise the point with endocrinologists, hey, when you write your letter to your GP, can you please mention about getting a GPCCMP? So having open communication, but also, valuing your time and sort of the training that you've done as well.
Yeah, exactly. And I guess before we sort of talk a little bit more about some transitional arrangements, what I was thinking too, Luke, is that the quality of the communication between the allied health provider and the GP can be a real marketing advantage for allied health providers as well. So making sure that your communication back to GPs is helpful for them and for the patient, that's going to be your best bet in ensuring that they're going to refer back to you next time because they think that what you're providing is useful. They have oversight and they understand where you've been, what you've been doing, and that clarity is very helpful from the GP perspective as well. So some great tips in there. Luke, did you want to just kind of run through this particular issue or scenario that was part of the MBS online as well in relation to the validity of referrals from before the 1st of July? Talk us through what we've got here.
Yeah, so just an FYI, guys, you can find this example and many other examples on the explanatory notes on the MBS online. So this example is talking, I'm a diabetes educator. I assessed my patient as suitable for group diabetes services with type 2 diabetes before the 1st of July 2025, but they haven't attended any sessions to date. Are they still eligible for those group services from their GP management plan? And the easy answer, short answer, is yes. They are
That's
entitled
it.
to those services up until the 1st of July 2027.
Fantastic, excellent. And in addition to the MBS online that we've kind of been coming back to a few times during this session, just want to point you to that I've put together for you a quite detailed Medicare guide just for allied health professionals, and the team at Westvic PHN will issue that to everybody who's here tonight, and certainly it'll be part of the resources if you're watching this as the recorded version. The guide gives you sort of the clean version of the MBS online in relation to allied health, service opportunities, item numbers, with lots of hyperlinks straight through to MBS online as well. So hopefully that will help you to really get your head around the spaghetti that Medicare often is. I also wanted to just lean into the opportunity for the provision of case conferencing. So case conferencing is a service that GPs have been able to tap into together with specialists and certainly allied health in times gone past. But it was I think about a year and a half ago, when allied health professionals got their own MBS item numbers for participating in case conferencing with GPs and specialists as well. So that was a really big change, but it is still flying under the radar. It does for general practice, and I'm pretty confident it does for allied health as well. So my job is to talk about it both with the GP cohort and you guys as the allied health providers, so that you understand that where you are dealing with complex patients where a conversation between the care team could be really helpful in understanding the circumstance of a patient, planning what services are going to be provided, and sharing that information can be done, and it is absolutely supported by Medicare. So the item numbers that you would be looking at, and this is all allied health modalities, unlike the GPCCMP services, these are the same regardless of what type of allied health provider you are. So we're talking about item 10955, which is for a case conference that lasts between 15 and 20 minutes, then the 57 and the 59 for the additional time. So depending on how long this case conference goes for, depends then on the item that you will charge for that, and the Medicare rebates obviously are higher for the higher time tiers as well. The key requirements for undertaking case conferencing is that the patient must have a care plan in place, and the case conference must be organised by the referring GP or consultant physician. So although you could absolutely tap the GP on the shoulder and say, hey, would a case conference be a good idea for this patient? And they're very likely to go, actually, that would be a great idea. The instigation of it must happen from the GP perspective or the consultant physician. Again, this is just all in the Medicare wording on what an organizer is responsible for doing versus what a participant is responsible for doing, and you would be the participant. So keep clinical notes, make sure that you've obtained consent from the patient to allow that case conference to happen. The patient may be present, but they don't have to be. So again, it's quite a different space. We could probably talk for a whole hour just on case conferencing alone. And the key requirement is that there need to be 2 additional health professionals present in the case conference in addition to the GPs. So the case conference is a group of at least 3 health professionals getting together and having a bit of a natter about the patient. And the really good thing about case conferencing is that they can be undertaken every 3 months. So not more frequently than that, but 4 times a year for chronic complex care patients. You can supplement your communication and your service provision through case conferencing again. And I hope that you'll have a bit of a think about how that can impact on the patient health outcomes that come along with that as well. So we've already talked a little bit about Luke's experience. I kind of threw that into the mix a little bit earlier on, but I guess I do want to ask Luke, when we started talking about all of these services and, where did you start off from in terms of your knowledge and understanding, and what was surprising in the conversations that we've had and with what you've learned?
I think so. Like I said earlier, transitioning from the public hospital system to sort of a semi private sector, the whole billing process for me was a completely new language. I specialize in the education I provide, but then there's this billing and Medicare, component on top as well. Getting register with Prada, that was a process itself. Making sure that you're an eligible Medicare provider. So I actually had to observe some of my colleagues just because I couldn't offer my services because patients wouldn't be able to get a Medicare rebate. So learning sort of those Medicare rebates was quite an interesting experience. But then when I was seeing patients with a team care arrangement, you'd send them off to reception to do their billing, but there would be no EPC plan in place. So then reception would have to contact the GP practice to try and get that faxed across. So was quite a clunky billing process. So definitely this new arrangement has definitely streamlined things, particularly with billing as well.
Yeah. Yeah. And look, it's interesting to hear of, your early experiences and the complexity of Medicare. And I think if others in the room tonight too are kind of going, yeah, I actually find it really difficult to get my head around it. It's Medicare, it's not you, it's the system. It really does have a high level of complexity to it. And very often, common sense has kind of been pushed to the side a little bit in terms of what Medicare requires of you. But there is legislation that sits behind all of this. So this is why we lean so heavily into making sure that when you do intersect with Medicare, you do it in a compliant way. Because if not, they could come knocking on the door and ask for rebates to be paid back. And it's a whole world of pain. And we don't want that to happen. Now, I'm mindful that we're really coming to the end of the hour, and I can see there's a lot of comments in the chat. I'm going to come to Fiona in a moment to run through some more questions. I don't know about Luke. I'm very happy to stay a little bit longer to make sure that we cover off on all of the key questions. But some of the key implementation tips, and again, Luke, feel free to pitch in, when you want to participate. Just the acceptance of electronic referrals. Get yourself set up to be able to link into Argus, HealthLink, all of the various modalities in which you can receive electronic referrals. They can't get lost, and you've got the evidence of it. It goes right into your management system, and it kind of really streamlines the way. So ditch the facts. That's the big message in that. The communication with the general practices that refer to your services. So let them know what your wait times might be like, what your preferences are or your capability is to receive the referrals, including the old EPC referrals. So ensuring that they understand that you're still happy to work under that framework as well. Your billing system. So make sure that the general practices are also familiar with your billing structure, and certainly not if down to the last dollar that you'll be charging, that either you are a bulk billing practice or provider, or you're a private billing provider. That's really helpful for general practices to know that as well. We want to ensure that you think very carefully about your billing system to ensure that you as a provider are not left carrying a debt, i.e. the patient's walked out, you've intended to bulk bill, they've already reached their limit, and Medicare is not going to pay. That's going to be a hard task to chase that patient for payment if they are already out the door. And then, of course, ensuring that when you get new referrals coming through, that you communicate really clearly with patients about what the expectations are, especially around billing as well. The awareness around Indigenous status, because of the ability to tap into the 813 item number series with double eligibility, very helpful for Indigenous patients. And then the opportunities for case conferencing. And out of that, I guess, Luke, what's your favorite tip, or is there anything else that you think is a really good idea for our colleagues to know about?
I think, valuing your own worth. You've done whichever allied health modality you work in, you've done a lot of training to get there. And obviously you need to be remunerated, for your sort of time. Being open and education, like we're all learning this system. GPs are learning this system, we're learning this system, patients are learning this system. So having sort of open communication with one another and sort of promoting what this service can provide, I think that's really important as well.
Fantastic. Great advice there. So we'll come to some questions. And Fiona, I might ask if you are happy to perhaps field some of the questions. I'm presuming there might have been a little bit of overlap with some of the questions. I'm going to leave the resources page open here with some contact information. If you want to get in touch with myself or with Luke, our contact details are provided there, and we would absolutely welcome that from you if you've got any questions that you want to throw our way after this session. So over to you, Fiona. Hit us with some juicy questions.
Thanks, Riwka and Luke. That was a fantastic presentation. And yes, there's a lot of comments in the chat. It's great to see people actually helping to answer each other's questions. So keep doing that and sharing your knowledge. We have a couple of questions up front about at the beginning of the session around item numbers. So looking at the allied health, the diabetes group sessions, is the allocation of the H1115, is that 8 or 7 appointments at the 19 and the
Yes,
75?
it's up to 8 group services per calendar year, and that is across each of the or all of the modalities. So that is 8 across exercise physiology, diabetes education, and dietetics in the aggregate, not 8 for each modality. So, and of course, for the type 2 diabetes educators, I'd be thinking, why not get an EP, a dietitian, and a diabetes educator together for, some really good group work? Now, just be careful, because obviously the allied health providers do need to work individually and ensure that they meet all of the compliance requirements. But wouldn't it be fantastic to perhaps, run a 3-hour session where you have an hour each with each of the allied health providers, and you kind of group them together? It's a good way to get a group together and to get some really content and group services going. And of course, then that's 3 services that are being provided kind of in one block. And all of the allied health providers are also sort of learning from each other. It kind of starts to lean into that space of case conferencing as well, that, we're understanding what our strengths are, what our service priorities are, and what individual patients are needing. And don't forget, like, the group services are just so fantastic, because there is nothing better than getting patients together to share their experiences. That lived experience and sharing stories is possibly of even higher value than the clinical input from the allied health providers. And I'm certainly not diminishing that, but just the value of patient voices and hearing congruency among stories can be incredibly helpful for patients to better understand their condition and network, meet some new people, make some new friends. It addresses that whole sort of mental health space as well. Honestly, if you want the tick, 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 group services would absolutely be, one of those key opportunities there.
And just reiterating what you're saying, Riff, there may be a participant who has a question, and if you were doing a single consult, they wouldn't ask that question. But the fact that someone else has asked it for them and they get the answer, it's great. It's that sharing of communication and information.
Great, thank you. There's a question from Emma. As a dietitian, often needing to assist clients by doing meal guides and plans, which they need to bill for. Clients ask them to claim a chronic condition management plan session for this work. So to ensure we remain compliant with Medicare claiming for this, would we need to ensure that have the client present for at least 20 minutes of, say, a 1-hour session that we bill for?
Yes, absolutely. So that face-to-face and interactive component needs to be at least 20 minutes. It doesn't count for the work that's being done in preparing, meal plans or regimes or whatever you might call it. So that's exactly right. 20 minutes face-to-face is required.
Great, thank you. Maria's asking for the services for family and carers, so that's under better access, I think.
Yes.
Is this under the same referral or a separate one?
That would be a separate referral. So it would be a referral for a carer. Again, it would be, well, actually, that may not be correct. It may well be that this is a recognition by an allied health provider who's providing services to a client, and then realizing that there may be a family or a carer involved who could also use some psychological support. So I'm actually going to backtrack a little bit in that and go, Maybe not, but this is absolutely one of these areas where we need to go back to the Medicare explanatory notes to see exactly what those referral processes require or not require. So I'm going to take that one on notice, as the politicians say. And Fiona, I might send my response back to you, but I'm going to invite everybody to go and look up the item numbers and see if we can land on an answer there that that is suitable. And I guess my ambivalence there absolutely is related to the fact that I did not even know that these two services were available until quite recently. So, like Luke was saying, we're all kind of learning as we're going. And it's funny too, Luke, did you want to tell the story about actually providing services and then realizing you didn't have a referral form at all, and not quite realizing that that was actually really important? That was a conversation that we had too, all about learning and correcting as we go.
Yeah, so I was just sort of telling Rifa the example of a patient that I received a referral for, but it was a referral. It was a letter to myself, but it didn't specify diabetes education. It didn't specify on the referral letter what they were wanting from my service. So that was a really sort of good pickup and something to be aware of as well. Just making sure that you do read through those letters and make sure they do tick all the boxes, and you do have an understanding what you're actually providing to that patient.
Yeah, exactly.
Great, thank
So
you.
I've since followed up with the GP practice about this, which
Okay,
is, yeah, it's tricky. It's extra work, but it means that it's all legit.
And I'd say the GP practice will be most impressed that you're following up and making sure that you're following those Medicare guidelines. It's very impressive. Fiona, back to you.
thank you. We have a question from Rebecca. If the start date of the 18-month validity begins from when the patient first accesses services rather than the referral date on the letter, how do we manage this if a patient is accessing services from a range of different providers?
So the answer to that is that it's relating only to your referral. It's not relating to other referrals to other allied health professionals. So you only need to manage your own. You are not expected to be across other providers and what they may or may not have done. So it's your referral form, and the validity, unless it's otherwise specified, starts from the first day that you are providing an allied health service. And then you don't need another referral form for 18 months, except if the GP has said this referral is valid for 6 months, or this is however, whatever language they might use. Then you will be happy to know that you can continue to provide services for 18 months, caveating that with the patient will only get rebates for 5 services per year. So beyond that, to sort of kick off that process again, you would need a new referral after the 18 months to kick that process off again. But of course, you could be providing many more than 5 services to the patient, whether it's per year or over a longer period of time. That's entirely between you and the patient, in accordance with their need and what the patient is prepared to pay for beyond the 5 services that are then not going to be sort of Medicare rebated.
Yeah, thank you. There's been a few questions in the chat about the last service report. So if patients don't have their 5th visit, what do we do then?
Yeah, well, look, I guess there's a couple of ways that you could approach it, right? You could make a habit of writing a quick note back to the GP after every service. That keeps things on track really, really nicely, and you'll never fall foul of compliance requirements. If that's not how you're working or the way that you want to work, as Luke indicated, you do need to write back to the GP after the first service has been provided. And then if there is sort of a cessation or a completion of a cycle of care, you need to write that again. But if the patient, hasn't dropped up, it is up to you to determine, should I have written on account of the service I provided 2 months ago, although that wasn't expected to be my last service. So how do you do that? I don't know. It's really messy, isn't it? Again, the practicalities of this are really, really difficult. And that's why I'd be saying, why not use your electronic communication mechanism to write a quick note to the GP after every service that's been provided? You will always stay compliant, and your GP will be so impressed of keeping them in the loop of the services that have been provided. And of course, if they've missed an appointment, they'll be happy to hear about that as well, because they may well be able to support you in encouraging the patient to go back and finish a course of treatment or services in accordance with, the established clinical need of the patient. So, it depends. It depends on how you work and the systems that you've got available. But I'd be saying do the same thing every time, because then, the holes of the Swiss cheese aren't going to line up, and you're going to have a crisis of either Medicare compliance, or other sort of, falling foul of the system. I will say, though, that of all the things that Medicare is very concerned about in terms of practitioner compliance, I don't think the writing of letters back to a GP and the interval of that is going to be highest on their list of priorities. So they're going to be far more interested in, if you've claimed an item number or the patient has claimed an item number, was the service actually delivered? That's going to be of much higher priority than did the right letter go out at the right time. And again, that's just my view on working with Medicare and how they tend to see these things.
Sure, thank you. John's asking, with the 18-month referral, can patients attend for 5 treatments 1 year and return the following year within the same referral period for another 5?
Luke, did you want to take that one, or do you want me to answer that one?
I actually don't know it, so if you can take
Okay.
it, that'd be great.
Yeah. Yes. No, that's exactly right. So the 5 per calendar year is the maximum limit of what is going to be Medicare rebated. But if the referral that you have is valid for an 18-month period, which generally it will be, when the new year kicks in, the reset happens on the 5 services, and you can start again with the knowledge that the rebate is going to be appropriate for the service that you're providing. And remember too, other allied health could be jostling for that work as well. I think, we do tend to get a little bit of uptick in work volume in the early part of the year, because that eligibility has opened up again, and we've got a little bit of rebate to play with. Later on in the year, when it's been exhausted, it might tend to sort of slow down a bit. But you do not need a new referral to kick off the new 5 services in the new year. I hope that's clear enough.
Thank you. Another question, in addition to the final letter, Marie asks, if you send a final letter, is the referral deemed closed?
No, I would imagine that it isn't, unless the GP referral has specified that they are looking for a time-limited or specific purpose service from Allied Health. So you need to go back to the referral and look at what was actually requested of you, and you need to stay within the parameters of what that request is. So it's very clear that that's delineated. I probably would say forget about 18 months. I think the referral is completed. I would like you to go back to your GP, have a review of your GPCCMP, and if the GP feels that some further services are warranted, get them to write a new referral, and I'll be more than happy to do that. That keeps you absolutely clean as far as Medicare compliance is concerned. And again, it stays true to what the GP requested of you, maintains really good relationships, and ensures that you kind of adhere to what the GP has asked in terms of that service provision.
Great, thank you. Maria's asking, can two allied health be from the same clinic?
As in two, yes. I presume we're talking about two different service providers and different service modalities.
Yes.
Yeah, absolutely. It's not related to a physical location. It's related to provider numbers for allied health professionals. Of course, each of them needs to be registered with Medicare, and they need to be credentialed in the way that their modality needs to be credentialed. But just because they are at the same location doesn't preclude any kind of service provision. And again, if we're talking about type 2 diabetes patients, then that sets the scene for some fabulous group services and perhaps case conferencing as well. So it's really desirable.
Great, thank you. Sonia's asking, we received GPCCMP's then a review. Are we to do the final reporting at the expiry date in 18 months?
Look, again, I guess I'd be speaking to your GP practice about what their preference is. I think it's tricky to know exactly when that GPCCMP expiry will be, unless you're looking on Proda. You might not get that absolutely right. You'd need to have reminder systems in place to ensure that you sort of coordinate that. It sounds like a lot of hard work. That it's not that you couldn't do it, but it sounds from an administrative point of view a little bit painful. So I probably would be saying you're better off, and we haven't spoken about this at all. If you're using practice management software, or you're managing your clinical services through a software provider, there are fabulous AI support tools available that will help you put together fabulous response letters back to GPs and anybody else that you're intersecting with, that take you no time at all. Great quality, related to the service that you've provided, and will take minimal time on your end in order to get that going. So think of technology tools to smooth all of that over, right back, make sure that you get all of that done. This is where the market is absolutely going. I'd be saying, if that kind of technology sort of freaks you out a little bit, I'd be saying your competitors will probably start thinking about these things soon. So where is the market at? What can you do better? And how can you make your own workflows as seamless as possible to make sure that you cover all of these compliance requirements, the communication to patients, to doctors back, make it as easy as you possibly can. There are some really fantastic tools available that will help you to do that right now. And I'd be spending my dollars that I'm gathering from my private billing to support exactly these kinds of tools. And I'm being a little bit tongue in cheek, but I actually do mean that.
Just adding on to that, Riff, I've spoken with colleagues in the diabetes education space, and this is certainly an area that they are investing in. Remember, time is money, and if it means that you can pay a little bit of extra money for a service where you're actually saving time, then that's definitely going to be beneficial in the long term.
Yeah, I couldn't agree more.
Great, thank you. Tanya's asking, I've had GPs write one visit on new management plans. Does that mean they need to get a new referral after that visit?
Yeah, yes, I think it does. Look, technically speaking, if the referral time frame isn't specified, you wouldn't be beholden to the one service, because Medicare will just pay up to 5. It's essentially, it's up to the patient to determine how many services they're prepared to undertake, whether it's privately billed or whether it has a subsidy, a Medicare rebate attached to it or not. But it's a negotiation between the patient and also just the communication back to the GP. If they've specified one service, I'll bet you that the GP hasn't quite twigged onto the idea that they don't need to do this anymore. They're just not, they're not across all of that. Or they're thinking that they're going to make your life easier by saying, just do one because I've also referred the patient to other service providers. So they can put that in there. It's not going to hold any sort of legal weight, but think about the expectations and also what the patient understanding is of where are we at now, what can I provide for you, what do you agree to, and where are we going to go from there. So essentially a referral is valid for the 18 months or unless otherwise specified, and it also doesn't say that if the GP specifies the number of services to be provided, that holds true. That's just not a thing anymore. So you're free to be a little bit more entrepreneurial about that, I guess.
Thank you. Beck's asking, as a podiatrist, if we see an Indigenous patient, do we bill an 813 or a 90163? And where do we find these exact billing codes?
Okay, so the exact billing codes, you'll find the information in the resource guide that you're going to get as a resource, and the information comes from MBS Online. You'll find it all there. In terms of which item number would you use, you can use either. So again, think about how many services are we wanting to provide. So if the patient has already received, say, 5 services that have been Medicare rebated through the 109 numbers, then you can flip across to the 813 item numbers and know that you've got 5 more services for which the patient is going to get a Medicare rebate. If they haven't received any services, you can choose. It actually doesn't matter which one you pick. You're going to get paid the same amount. The Medicare item descriptors are essentially the same. It's only the volume of eligibility that's different between those item numbers. So it's up to you in terms of which item number you choose. If it was me, I'd probably go for the 813 item numbers, only because then you don't need to flip from one to another. You know that there are 10 available across the year in that item number, and then we don't need to worry about the other item numbers at all. But again, you're free to pick and choose, and if you want to flip between the two, you can even do that. Medicare's not going to care about that. They'll just stop paying after 10 services have been rebated. It's a mess, isn't it?
Here's a question from Marie. If a GP does specify a preferred number of visits, can we ignore this if the patient requests otherwise?
Yes. The short answer to that is yes. We spoke about that just before with the previous question, that if the patient would like additional services, there is nothing to stop that from happening.
Great. Quite a few of the same type of questions. So I'm just having a look through. Do patients need a separate referral for group exercise physiology compared to the standard 5 allied health services?
No, they don't. They can use the same referral form. So what would need to happen though is it would be a good idea to just contact the GP practice. It's not an absolute requirement, but might be nice to do. You would then kick off the service with an assessment. So remember the 45 minutes plus assessment needs to be undertaken to identify the readiness for patients to undertake group services. And again, within the Medicare explanatory notes for each of the modalities, you'll get far more detail about what is expected to be covered in those assessment processes. And it's, of course, different between the dietitian, the diabetes educator, and the exercise physiologist. So the one referral coming out of the GPCCMP, if you say a group service would be really good, off you go. You can go and provide that, which is great, right?
Great, thank you. Thank you to Ruby in the chat. She's been answering some questions and popping some links in there. So thank you very much. Here's a question from Leonie. If a patient provides a new management plan in less than 12 or 18 months, does this override the previous referral?
Well, it wouldn't override a previous referral. It would simply be an update to the GPCCMP. So remember, there is no such thing as a GPMP and TCA anymore. And in essence, a GPCCMP becomes a living document that is simply updated, whether it's through a review process, the 967 item number for GPs, or whether after 12 months they claim a new GPCCMP. It actually makes no difference. The money that they receive is the same. And in essence, GPs would be unwise to throw out a previous GPCCMP and start again from scratch. You would imagine once it's established, it's just a living document that just gets updated and refined and kept contemporaneous over time to track where the patient is at any point in time. So no, a new plan does not override the referral, but there may be, additional allied health services that might be required as a patient's healthcare journey progresses over time. Again, if they've already had 5 rebated services related to other modalities, then then that's okay, and there won't be a Medicare rebate that's associated with it. But if there is, then other modalities could certainly be added into the mix.
Thank you. We just have 2 more questions, so we'll probably
Great.
squeeze them in.
Sure.
John's comments, often elderly patients who present do not remember where they have used their services.
Yes.
Post-consult, when claiming through PRODA, we eventually find out whether we will be paid or not. Do you have any views on this?
Yes, I have a view that that's exactly how real life works. Patients don't remember. They actually find it really difficult to discern between what's a GP, what's an allied health provider, and sometimes even a specialist. So patients find all of this very, very confusing. Yes, PRODA can be helpful for that. I guess, again, I'd be coming back to what's your process, what's your billing process, and how do you deal with that? Think about the patient in front of you. Are they cognitively able to sort of backtrack and think of this information? Would it be fair and reasonable to give them a hand and get some clarity about where is this patient at? Are they going to get a rebate or are they not? From the point of view of affordability, can this patient afford your service at this point in time when you don't know whether they're going to get a Medicare rebate or not? It might make the difference between whether a patient would choose to undergo the service or say, just hold on, I need to wait until I have a few more funds. And if that's the case, I think the right thing to do would be to take the effort, go into PRODA, have a look and see if you can work out what the eligibility is looking like and help the patient along. For the general public, I probably wouldn't be that generous, only because, this is quite an administrative burden for you and your practice, and you certainly wouldn't want to be doing this for every client that you're servicing.
Right, thank you. And I've just got one more question from Caroline. If you have treated a patient under a CCMP for type 2 diabetes and they want to start a group, can you bill for the assessment for the group?
You bill the assessment per patient. So every patient who is intended to go into a group needs to have the assessment, which is an individual service. So it's the assessment that kicks off the eligibility to participate in a group. Does that answer the question?
Sorry, hello. If I've seen someone for individual one-on-one for 10953
Yeah.
for type 2 diabetes, and then they want to do the group. They do want to do the group service. Do I need to do an assessment that
Yes.
bills under that ATO
Yes.
something?
Yes, you do. Yes, you do.
Okay.
Because unless you've billed that item number, Medicare will reject the group claim. So if you haven't done the assessment, Medicare is going to go, this patient's not eligible to receive a group service and you're not going to get paid it. So yes, for every patient, even if you've seen them individually, you need to claim that assessment item before you undertake any group services. But yeah, it's a great question.
Okay. Does the referral that if they've sent me a referral for the individual, does the GP need to send another referral for group exercise, or can I use that same referral?
You can use the same referral.
Okay, awesome. Thank you.
Welcome. That's good to hear some other voices. So if anybody else wants to pitch in and ask a question live, I'm all up for it. And I think Luke is too.
Great.
I'd like to ask the question.
Oh, here we go. Yes.
Just about that referral with the group exercise physiology. I know you have to have the 8110 first, but does the referral then still have to state diabetes group, or does it can still just, it would still have to have that on it? Okay, now that's all I just want to know, because we do a lot of group sessions where we work, and I just want to know, because we used to get the separate type 2 diabetes referral prior to the 1st of July.
Yeah.
So long as it's got diabetes group sessions, yes, we can just have a normal. Okay, thank you.
Great. I think you've answered your own question. So
Yeah,
there you go.
I just want to clarify.
Thinking
Thank
out
you.
loud. I love it. Great. Okay.
All right. We did pop an evaluation slide up. We might just pop that up again quickly, Jade, and we popped the link in the chat also. So please fill that out and let us know what you thought of the session. And I've just one last call perhaps for questions for Luke and Riwka.
Yep.
Perhaps not.
Sorry, what are you asking something of me?
No, I was just asking
Okay.
if there's any more last call for questions
any
from the
more
audience.
questions? Fair enough.
No, but possibly not. But now's a good time to say thank you very much, Riwka and Luke, for this session. It's been wonderful. Thank you very much for all the participants' questions and comments and answering each other's questions in the chat. That's really great to see as well. So thank you very much for attending, everybody, and please fill out that evaluation for us.
Fabulous.
Sorry, Fiona, and sorry, guys. I just wanted to ask one last thing. Since with the same diabetes question, if they do the assessment and they're eligible, are we allowed to send that back to the doctor and they can start group classes next year, or does it have to be redone again in the new year?
No, that's so it's valid for the entire validity of the original referral. So you don't need a new referral for the new year. Again, just remember only 8 sessions of group services can be provided over the year.
Sorry, I meant, for example, if I assess the client this month, obviously because there's someone that's I'm doing with, do I have to reassess again in the new year, or can they go straight to group next year?
No. So the assessment is a one-off service, not a repeating one every year.
Okay, thank you.
Thanks, everybody. Thanks for your attendance tonight.
Thanks. It's been really joyful, and I'm so glad to have had Luke as my wingman on this session. And I really appreciate all the questions and your keen interest in this topic. So again, feel free to reach out to Luke or myself if you've got any other follow-up questions. We'd be more than happy to answer anything else that might pop up.
Sorry, Riff, just before you go.
We're going to be here all night. No, that's fine. Who's speaking?
Marie.
Oh, hello, Marie.
Hi. Just in regards to the groups again, this seems to be where a lot of confusion is also. When they have the 8, after their assessment, they get 8 visits. Does that leave them 4 visits for other services on the original?
No. So remember, the group services are a completely separate group of services compared to the individual face-to-face. So they can have 8 group services, plus they can have 5 individual services that they were probably originally referred to. So those 2 things are really quite separate, but they can be delivered in tandem. And of course, the beauty of it is that if you add the 5 individuals together with 8 group sessions, all of a sudden you start to get a far more robust support framework for these type 2 diabetic patients. And that's the whole intent behind the program, that through various modalities, we can get a lot of services provided, but it may be just a little bit left of center from what you've been thinking and necessarily, you know, what has been referred to you in the first instance. So it's about the awareness that this sort of lurks in the background and what can you make of it. So if this has kind of really inspired some of you to go, oh, this actually sounds like a really great idea, that's kind of where we've wanted to land tonight, to get you to really understand the breadth of the service opportunities, and then you know, having a go at implementing that and getting your patients together. So, and again, of course, it's not applicable to all allied health professionals, and it's only for type 2 diabetic patients. So it's constrained. It's not a free-for-all. It's not for every patient with a chronic condition, but you know, there are many type 2 diabetic patients around. So it really does give a really good scope for service provision for that cohort.
Perfect. Thank you so much.
Great. All right, Fiona, I'd say we better wrap it up because I'm sure these poor people need to get some dinner as they look at us.
Absolutely. Thanks again, Luke and Riwka, and good night, everybody. Thank you.
Thanks for your attendance. Take care. Bye-bye.